services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together. I know it's a hard time, but for goodness sake, it's the best profession in the world. Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes. Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
Something I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
It's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together. I know it's a hard time, but for goodness sake, it's the best profession in the world. Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes. Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is...
Something I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
It's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together. I know it's a hard time, but for goodness sake, it's the best profession in the world. Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes. Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
Nothing, I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
It's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together. I know it's a hard time, but for goodness sake, it's the best profession in the world. Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes. Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, Please speak to the organisers and visit the website, and I really hope that we'll see you at that. These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators, anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
Nothing, I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
That it's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together. I know it's a hard time, but for goodness sake, it's the best profession in the world. Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes. Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Welcome to the Midwifery Hour this Wednesday evening. My name's Neil Stewart. I'm the editorial director of the Maternity and Midwifery Forum. Sue MacDonald, your usual host, is on a train somewhere around the Midlands. So tonight I've been given the joyous task of leading on a Midwifery Hour looking at exploring awareness of genomic testing at the initial midwifery appointment and introducing many of you to the whole issue of genomics in maternity and midwifery. And I'm joined this evening by Jo Hargrave, who is the lead midwife on the East Genomics Medicine Service Alliance, and by Karen Creed, who's the lead midwife on the Central and South Genomics Midwives Science Alliance. I need to warn you that the geography of these doesn't follow the geography of the NHS, but I'm sure we'll manage to get our way through. So Jo and Karen, welcome. And what's your moment of the week? Let's start off, Jo, with you.
So yeah, mine's probably a little bit morbid, but I'm really excited about it. So a year ago, I took my cat to the vets, and I was told that sadly she was not going to survive very long, so sort of 6 weeks. However, here we are a year later, and she's got superpowers, and she's still here. So I'm celebrating that my gorgeous cat is still with me and going strong.
Okay, still got some of its 9 lives left. Karen,
Exactly.
what's your moment of the week?
So my moment of the week was on Saturday. I love running park run, and I've been doing it for about 5 years now. And I did my 130th park run in Bushy Park in London. I was staying down there with friends, so I thought, let's do it in the home of park run. And it wasn't exactly the London Marathon, but for me, it was my marathon. So yeah, I just had great fun and met a lot of nice people. So that was good fun.
Oh, very interesting. Well, reading about genetics in the genome, of course, there are lifestyle choices that people make that can have an impact on all of that, no doubt we'll come to with regard to midwives. So we'll come to our 2 guest speakers in a few moments. But first of all, let me just bring you up to date with some news and the news of the week. A big shout out to everybody at the Royal College of Midwives Conference in Birmingham. Hopefully they're all putting the world to rights and getting all the pay increases, the new roles for consultant midwives, all the proper grading problems sorted out, all the extra midwives needed in the university sector. What could possibly go wrong? But to everybody who's up in Birmingham, all the very best of luck. We have a Maternity Midwifery Festival on the 20th of May in Nottingham. So anybody who can get there is welcome. It's free to attend, and it's worth about 6, possibly 7 hours towards your revalidation. And as I say, it's free to attend. We will have a presentation there on genomics when people will get the chance to see Jo again. And we'll also have a big presentation on birth trauma. Many of you may have seen the stories in the media at the weekend from the former MP, Theo Clark, who's written a book on birth trauma and is working with the Birth Trauma Association. And I think the rest of the world is just beginning to discover the scale and the many issues that can lead to trauma before, during, or after birth. And I think it's going to be a very big issue over the coming years. On the 8th of May next week, for those of you who are followers of Matflix and have it on your university resources, libraries, or in your trust, we're running an online webinar at 1 o'clock on the 8th to make the most of Matflix. In other words, how to use all of these videos and things. And the video that Jo and Karen made last year, teeing up some of the issues around genomics, is currently showing on the Northwest websites, and they look like they're making good use of it all. But making the most of Matflix is something that people are having to get up to speed on. I'm doing a briefing for a university in New Zealand in a couple of days, so some of this is going worldwide. For those of you who don't have access to Matflix because your institution doesn't have a subscription, we've brought in a new $2.99 a month subscription so that you can get access to all the back catalogue of all of these videos. They tell me that I have to say that that's less than a cup of coffee, but I never pay for coffee in any of these places, so I wouldn't really know. But that gets you access to all 1,600 of the videos and the 70 or so box sets. The 5th of May, in a few days' time, will be the International Day of the Midwife, and the ICM are running some online programs which people should try and log into. The 12th of May turns out also to be the International Day of Nurses, and of course in many countries midwifery isn't really allowed to be a separate practice, including some states in the USA where you have to be a nurse midwife, and there's no practice in the way that we would necessarily recognize it here. And you've just missed World Immunization Week, which finished today. And immunization of children is absolutely crucial, as they're discovering in some parts of the United States where measles is breaking out. So that, I think, is most of the news. And we can now turn to our topic for this evening, which is exploring awareness of genomic testing for midwives and in maternity. 25 years ago, in June, I was in Boston, Massachusetts, in the United States, at the biggest drug discovery conference in the world, when the first sequencing of the genome, or at least 90% of it, was launched at the White House by Bill Clinton and Tony Blair, with all the guys from the USA and particularly the people from the Wellcome Institute and the people in Cambridge who had done so much of the work. And there was a tremendous amount of excitement about the possibilities of personalized care, targeted treatments, the ability to figure out what was happening in many of the smaller conditions. but it was clear it was going to be a long road. So I was delighted when I discovered that I was going to get a chance to host this, where we will be able to hear how genomics and genetics is finally moving into the mainstream and really providing hope and some clear treatments and progress. And the role of midwifery and maternity and the role of the midwife is going to play a central role in that. We know that many of the areas of progress in genetics and genomics will be around cancer and a whole variety of adult conditions. But there's no doubt at all that the ability to do some kind of investigations and screening at that point when people have either become pregnant or are on their pregnancy journey is going to be very central. And I think the message is that if you're a midwife under 65, you're probably going to see this appearing in your practice within a year or two. We usually say that this applies to Gen Z and millennials, etc. But actually, I think it's going to arrive quite soon. So, can I introduce our two speakers for this evening? The first is Jo Hargrave. Jo is the lead midwife for the East GMSA and has completed an MSc in genomic medicine. She has over 18 years of experience working within screening and fetal medicine. She has a specialist interest in non-invasive prenatal testing and has acted as an NIPT advisor based with the Safe Test Laboratory at St George's Hospital. Her current role includes providing advice and support on national and regional projects, including the Newborn Genomics Project. And she does much more, and she will tell you all about that. And let me tell you about Karen. Karen is the lead midwife for genomics in the central and south area, which, as far as I can see, nearly reaches Wales and includes the Isle of Wight, or certainly Bournemouth, and is somebody else's idea of a region, but so it's certainly got the population of it all. She has over 30 years midwifery experience at both trust and regional level. She first developed an interest in genomics while working as a lead ANC fetal medicine midwife and later as screening coordinator, which led her to completing a postgraduate certificate in genomic healthcare. In her current role, she's particularly focused on education and raising awareness among midwives of the potential that genomics offers. And before this program tonight, Karen did have to remind me not to get carried away with potential. This is a journey for people. There are possibilities, but not all of them have arrived yet. So over to you, Jo. Let's take us through your presentation. The screen is yours.
Oh, thank you so much. What a great introduction. And as Neil mentioned, this is going to be a whole series throughout the year, and we hope that you can join us on that journey. And that journey is about personalising maternity care within genomics, because as we can see, maternity care is evolving and genomics is at the heart of transformation. And by integrating genomic insights into pregnancy planning and prenatal screening, healthcare professionals can offer more tailored, informed and compassionate care. So with that, in this presentation, we'll explore how midwives can support early detection and referral through examples of non-invasive prenatal testing, NIPT, and non-invasive prenatal diagnosis, NIPD. Currently, fetal medicine midwives, supported by consultants and clinical genetic teams, lead in discussions with women and partners about genetic conditions and further testing options. And these can streamline referral pathways, offering earlier opportunities to explore choices and next steps. So just imagine the impact on care if we could open up these conversations even earlier, empowering all midwives with genomic knowledge from the booking appointment, because that could significantly enhance early detection and support, improving outcomes for the expectant mother. and their families. And when we talk about detection here, we're not talking about detecting a specific condition necessarily. It's about thinking about detecting those clinical cues or predispositions. So therefore, the aim of this session is really to think about how the midwife can improve the experience for women and their families, and also highlight one of the key resources that's available to you. We also then want to give you a brief overview of how prenatal screening and diagnosis has transformed over time, really focusing on NIPT and NIPD. And then we want to consider the midwife's role with NIPT and NIPD at the booking appointment by reviewing a couple of case studies. So, a key component of advancing genomic awareness in maternity care is understanding the resources available to midwives and other healthcare professionals. One of the most important of these is the National Genomic Testing Directory. And this directory provides crucial guidance on genomic testing options, empowering midwives and other practitioners to integrate these tools effectively into practice. And this directory lays the foundation for informed decision making and emphasizing the pivotal role midwives play in translating genomic knowledge into practice. So understanding genomics is becoming increasingly critical in maternity care, and midwives are at the forefront of these early conversations. So tools like NIPT and NIPD are excellent examples of how genomics can help detect potential conditions early in pregnancy. However, it's really vital to emphasize that these are just part of a broader spectrum of genomic conditions, and we just do not have enough time today to talk about them fully. But at the booking appointment, midwives have a unique opportunity to engage parents in discussions about family history, genomic red flags, and share knowledge on available testing options or next steps. By possessing high-level knowledge of genomics, midwives can empower and support families to make informed decisions. Having a basic understanding of those key components of genetics ensures timely interventions, appropriate referrals, and improved outcomes. So, while many families are happy and content with living with or experiencing genetic conditions in their families, it's really crucial to consider the positive outcomes of a timely referral to genetic and fetal medicine services. Missed or delayed referrals means the reduced opportunities for those early discussions and interventions, potentially limiting the woman's ability to make informed decisions about her pregnancy. And this can lead to feelings of guilt, blame, regret, what ifs, and then furthermore, feelings of anxiety and stress. Early detection and intervention can significantly reduce those worries, providing reassurance and clarity for the future. And this emotional support can positively impact on mental health and overall well-being. Delays to the referral can also result in financial strain, such as loss of income due to the need to attend appointments and treatments. And also thinking about potential late interventions often require more intensive and prolonged care. Lastly, choices influenced by religious or cultural beliefs may no longer be available or risk isolation from those support networks. And detecting genomic conditions early in pregnancy can also significantly impact the wider family. The pressure to inform family members about unexpected diagnosis can strain relationships, causing tension and conflict, leading to disconnect and sometimes the breakdown of relationships. And especially when we're thinking about, disagreement on ongoing management plans for that pregnancy. The diagnosis often necessitates changes to family planning and expectations for the future, which may challenge traditional views on family size and structure. And this can result in the reevaluation of reproductive choices, which can be particularly difficult for families with strong cultural or religious traditions. And providing support and resources helps families navigate these challenges, enabling informed decisions and fostering a supportive environment. Now, we've taken that into consideration, I want to take a step back and look at the bigger picture of genomics, and just show you how the times have changed in terms of testing, especially over the last 20 years. So in the past, invasive tests like amniocentesis and chorion villi sampling, or CVS for short, were the primary methods of diagnostic testing conditions. We can see in the 80s, there was the advance in DNA testing, allowing for more detailed analysis of genetic material. And by the 2000s, improved chromosome testings could detect smaller gene variants, allowing for more accurate results. And now today, we have whole genome and whole exome sequencing, which can find rare genetic changes, helping to diagnose conditions that were previously unknown. However, all these tests still require that invasive technique. So that needs that insertion of a needle through the tummy into either that placenta or the fluid around the baby to get a sample. What has been even more exciting is the discovery of cell-free placental or fetal DNA and the progression of non-invasive prenatal testing. So I'll always say this, NIPT, which is a screening test, and non-invasive prenatal diagnosis, NIPD diagnosis. In 2013, there was the launch of NIPD into prenatal services in the NHS for specific conditions, and NIPT as an evaluative rollout within the screening programme in 2021. So, unlike other methods, NIPT and NIPD use a maternal blood sample to either provide a likelihood of a specific chromosome condition or a diagnosis of a small number of genetic conditions definitively. And how is this done? So during pregnancy, the placental cells undergo apoptosis, cell death, and shed, releasing small fragments of DNA into the maternal bloodstream. And so roughly around 10% of that cell-free DNA circulating in the mum's blood is from that placenta. And this cell-free DNA becomes detectable as early as 7 weeks in the pregnancy. However, once that baby is born and the placenta is expelled, that cell-free DNA is rapidly cleared from the maternal bloodstream, and therefore that does not interfere with future pregnancies. And with these new technologies, bring more testing options to women and their families. And so I just wanted to go through very briefly some of those opportunities. I'd just like to highlight, I'm not a scientist, so I'm not going to go into too much depth with these. But first of all, we've got the NIPT, so that's aneuploidy testing for chromosomes. And this is used for screening for Patau's, Edwards, and Down syndrome. And the technology analyzes cell-free DNA to detect excess copies of these chromosomes. And as I highlight very much through this is a screening test. So any higher chance result will require confirmatory testing. Although it's highly sensitive, there is a small chance of a maternal or pregnancy-specific condition, which may also cause that excess in chromosome copies. And that could lead to a false positive result. And what that means is that the test indicates the baby has the condition, but they don't. Now, with non-invasive prenatal diagnosis, it uses different methods, which means that it has a high enough sensitivity that it's classified as a diagnostic test. And this includes the determination of fetal sex for X-linked disorders. And this is done by assessing the presence or the absence of the Y chromosome. You've also got the identification of the rhesus D positive sequence in a rhesus negative pregnant woman, and which I'm sure most of you have seen in your services to date. And then we've got the identification of single gene disorders, which can be done in several ways to look for a specific gene change related to a particular disorder. And examples of these include cystic fibrosis, spinal muscular atrophy or SMA, and retinoblastoma. And just to note, there are 2 testing labs for the single gene disorders in England, which is Birmingham and Gosh. And that concludes session 1. So moving on, we're going to delve into some interesting case studies, and unfortunately our colleague Marianne can't be here tonight to go through it, so I will go through it for her. But before we go into the specifics, I'd like to highlight the significant benefits and challenges of non-invasive prenatal testing. So firstly, safety. NIPT only requires a simple blood sample from the mother, eliminating that risk associated with an invasive procedure such as miscarriage or other complications. Secondly, improved accuracy. So compared to traditional first-line biochemistry screening, NIPT delivers more accurate results, enhancing in reliability of prenatal testing. And then finally, cost savings. NIPT reduces the need for referral to tertiary units or fetal medicine services, leading to more efficient resource utilization and lower overall costs. And this isn't just for the clinicians, this is for patients too. They're not having to travel as far to go and see their clinicians. So while NIPT offers significant advantages, it's equally important to acknowledge its limitations. Firstly, limited scope. The NHS currently provides NIPT screening exclusively for Down syndrome, Edwards syndrome, and Patau syndrome. The positive predictive values for other conditions such as sex aneuploidies remains poor, which means that it's constrained to the broader application. And it's important to note that sometimes these are offered within the private sector. So if private testing has caused confusion or anxiety to women and their families, it's really good to link in with your fetal medicine or screening teams for further advice. Secondly, there are exclusions from screening. So in certain situations, NIPT cannot be used. And this includes vanished twin pregnancies, a history of an organ transplant, current maternal cancers, triplet or higher order multiple pregnancies. And in these cases, it is unsuitable for those pregnancies. Next is accuracy. So whilst NIPT is highly reliable, it remains a screening tool rather than a diagnostic one. And on rare occasions, false positive and false negative results may occur, warranting cautious interpretation. And then finally, diagnostic confirmation is required. So when NIPT indicates a higher chance, confirmation through an invasive test such as amniocentesis should be offered to ensure that accuracy. So this is just an image to show you that there are the two programs that offer NIPT. So we've got the fetal anomaly screening program, and it integrates NIPT as a secondary screening option. And it's offered for Down syndrome, Edwards and Patau syndrome. It's offered to women who receive a higher chance result from their combined or quadruple test. In contrast, with the with the R445 entry, this is specifically designed for women with a history of a pregnancy or child diagnosed with the full trisomy. And this pathway acknowledges the increased recurrence risk in such a case and offers NIPT as a tailored option. And with all of these, we still should be offering those women the offer of no further testing, non-invasive prenatal testing, or a diagnostic test. And it's important for healthcare providers to identify which pathway is most appropriate for the initial booking appointment. Ensuring this information is accurately gathered and discussed early helps to streamline that care and facilitate that timely access to the most suitable screening option for each patient. So I just want a moment of consideration before we move on to our case study. As we navigate this, I want to acknowledge that many of us may have personal, professional, or lived experiences related to disability, pregnancy, and termination. And these topics can be deeply personal, and perspectives may vary based on medical, ethical, religious, and personal beliefs. And our aims today is to approach this section with respect, openness, and sensitivity. So if at any point you feel the need to step away, then please do so, to take a moment or reflect. We hope that this space is open, thoughtful, and we appreciate everyone's presence here. So I want to shine a spotlight on Patau syndrome and Edwards syndrome. These are genetic conditions caused by an extra copy of chromosome 13 or 18. And typically, humans have 23 pairs of chromosomes, one set from each parent, making a total of 46. And in trisomy conditions, an extra chromosome disrupts that typical development. So with trisomy 18, which is Edwards syndrome, and trisomy 13, which is Patau's, these are life-limiting conditions, but the degree of impact can vary depending on the specific genetic presentation. Sadly, most pregnancies will, with a confirmed diagnosis, will end in a miscarriage or stillbirth. But for babies born alive, the survival rates are low. These conditions are associated with a range of severe signs and symptoms. Common features include microcephaly, eye problems, cleft lip or palate. There's also variations in hand and foot development, heart conditions, and kidney defects. Feeding difficulties and epilepsy are prevalent, along with severe developmental delays, all of which further impact the quality of the life, affecting the babies. And I just wanted to again put a spotlight on Soft UK, which is a really great organisation that can support families through this. But it's important to have sensitive multidisciplinary care because it's essential for supporting those families through a diagnosis, perinatal management, and palliative care, recognising the profound emotional and physical challenges these diagnoses may bring to families. So that brings us to our case study. So we've got Anne Jones. She's a para-naught +1. This is her family, or this is her history. So in her previous pregnancy, she'd had a higher chance combined test, which had identified a higher chance for Edwards and Patau syndrome. She decided to have non-invasive prenatal testing, which confirmed a higher chance result for trisomy 18 or Edwards syndrome. She proceeded with an amniocentesis, which then also confirmed that trisomy 18 result, but also had an abdominal wall anomaly on the scan. And Anne made the difficult decision to terminate that pregnancy. So we're now just going to walk through this current pregnancy, and she first meets her midwife, her community midwife, at 9 weeks. She informs that midwife of her previous baby with Edwards syndrome. She reports that she's really anxious about this pregnancy and doesn't want any screening. She just wants a diagnostic test. Now, this community midwife is aware that there is this pathway where actually she could have non-invasive prenatal testing instead of the combined screening, but she doesn't feel confident to discuss this with her and refers her to the screening midwife. And the screening midwife sees her quite quickly, and she sits and listens to Anne and her partner's experiences and recognises their concerns. They are made aware of that R445 pathway, but it's also advised if she would prefer that she could have no further screening or have an invasive test. And because Anne didn't realise that she could have that NIPT straight away, she felt she needed to go home, and it was really important for her to go home and consider those options. But she came back at 10 weeks and 5 days and had NIPT with a scan. So at 11 weeks and 2 days, Anne is informed that she has received a higher chance result for Patau syndrome and is offered an invasive test to confirm that result. She goes and sees a fetal medicine consultant where an ultrasound is performed and no anomalies are identified. And Anne is offered an option of a chorion villi sampling, CVS, but she's also offered to wait and have a second scan and amniocentesis later on in the pregnancy. But because of the anxieties that Anne and her partner have, they decide they want that CVS performed on the same day. A few days later, she receives her CVS result and it identifies a possible confined placental mosaicism and is advised to wait for an amniocentesis. At 15 weeks, she has that amniocentesis and the results show that there is a normal complement of chromosome 21, 18 and 13. And she has a live female infant at 39 weeks and 5 days, so a baby girl. So why did Anne get that false positive result? So there are, whilst I suppose NIPT is very highly accurate, false positive samples or results do occur, and that's due to several factors. It can be because of maternal genetic variants. You've got to remember that we're taking that blood sample from the maternal blood, and that is a mixture of maternal and fetal DNA. You've also got if the pregnancy was initially a twin pregnancy and one miscarried, sometimes the remnants of that DNA from the lost twin may still be detectable. And there's also technical limitations. Variability in sample quality, DNA fragment sizes, or errors in the sequencing can occasionally occur. And then we've got confined placental mosaicism for what we saw with Anne's case. So, and that's in some cases where the placenta may carry chromosomal conditions that are not present in the fetus, leading to NIPT to pick up an issue that doesn't truly affect the baby. So we really wanted to just take some key takeaways for you leaving this session. It's about acknowledging that previous pregnancy experience. And it shapes, unfortunately, these experiences do shape anxieties and expectations. So thoughtful discussion early on empowers those families to make informed decisions that align with their individual needs. There are 2 pathways to offering NIPT, but with the R445 pathway, women can be offered screening as early as 10 weeks gestation. Midwives understand the options at booking ensures that women are offered the correct pathway at the earliest opportunity. However, just want to make it clear, we're not expecting midwives at the booking to be experts in NIPT. We just want them to be able to have that fundamental understanding and knowledge of those timely referral processes. Considering timely discussions and informed decision making. So we sometimes think that women should be telling us immediately what they want, and we should be doing things quickly. In these cases, it's really important to make sure those families have the time that they need to ensure they're making the decisions that are best for their situation and individual needs. NIPT is a screening test, and higher chance results should be confirmed by diagnostic tests because false positive results do occur. That said, false negative results also occur. And in the absence of fetal anomalies on ultrasound scans, amniocentesis remains the gold standard for diagnosis with NIPT. So really just looking back at Anne's case, that community midwife did the right thing. She recognised that there was a pathway specifically for Anne's personal case, and she didn't feel comfortable with having that full conversation. She is not a screening midwife, she's not a fetal medicine midwife, and may not feel that that's appropriate for her, and that is absolutely fine, but she knew where to go and where to refer her to. I think it's also about highlighting that even if we do things as early as possible, it doesn't mean that the end of the journey will end early too. So it's just bearing in mind that there are complications, and learning about genetics is not always straightforward. So just to find out more, I've just popped on G-Notes, Knowledge Hub for NIPT, and this will just take you to a link to give you a little bit more information about NIPT, and also further links to key documents. And also again to highlight SOFT, which is supporting organisation for trisomy 13 and 18, that has some valuable resources and also stories from people living with these experiences, that you can go and see. So I'm going to end there and hand over to Karen Creed to talk about NIPD. Thanks, Karen.
Thank you, Jo, and thank you for a great introduction to non-invasive technology and a little bit of the history. And now that we've had a look at NIPT in more depth, we're now going to consider NIPD, that's non-invasive prenatal diagnosis. And what I'm going to do is first give a recap, so having a look at why we might perform NIPD, and then have a look at some of the benefits and challenges that this test might bring. And then I'm going to talk you through a case study that illustrates the difference that NIPD has the potential to make for families, and highlight some of the challenges this brings for us in midwifery. And then at the end, we're going to direct you to some further resources. So essentially what we're doing with NIPD is using the same principles, we're using the same technology, in that we are taking a sample of maternal blood and analysing some of the placental DNA. And we might use this, for example, where there is a pregnancy at risk of inheriting a monogenic condition, or we might use it for rhesus D-genotyping to prevent hemolytic disease of the newborn, or we might use it to determine fetal sex where there is a risk of an X-linked condition in the fetus. So let's have a look at the benefits. So first of all, it's safer. It's safer than invasive testing that we currently have, because we're only using a maternal blood sample. And of course, those of you who work in fetal medicine and screening will be aware of the anxiety that that risk of miscarriage with invasive diagnostic testing creates for women. Secondly, it's early, so we can perform NIPD as early as 8 or 9 weeks of pregnancy. And in fact, in some cases, we can get the results back before the point at which CVS would even have been available. But of course, we can only take advantage of this early detection if we get women into care early enough. So there's a challenge here for us in midwifery in terms of getting women seen and referred early. And finally, it's accurate in terms of the fact this is a diagnostic test, it's not a screening test. And so in many cases, we don't need to take confirmatory invasive testing. So, of course, we also have challenges with this technology. First of all, the scope of NIPD is limited. We can only offer it for a specific limited list of genetic conditions. And if you want to know which conditions are currently available, then head along to the National Genomic Test Directory, and you'll be able to see in there where we can offer NIPD and the inclusion criteria for offering those tests. There are exclusion criteria, so it's not available to everyone. So for example, in multiple pregnancies, or if you've got a vanished twin pregnancy, or if the mother has had an organ transplant, then we wouldn't be able to offer NIPD. And now you'll also see on this slide that I've included close relative couples or close relative relationship or marriage. And at the moment, you can't offer NIPD for couples who are in a close relative relationship. However, we know that that's going to change imminently. We've heard that it's going to be included in the next version of the Genomic Test Directory. So that's a really important step forward in the story of NIPD, because we will be able to offer it to an increasing number of people. There are Also issues in some cases where we need to undertake a pre-NIPD workup. So we need to do additional tests before we get to the point of offering NIPD. Now, in an ideal world, we would offer these tests preconceptually, just to speed things up, so we can offer NIPD as soon as possible in the pregnancy. But of course, if someone comes to us with an unplanned pregnancy or presents very late in pregnancy, then that might delay the point at which we can offer NIPD. There are also specific requirements on the type of samples that we require in some cases. So in some cases, we need samples from both biological parents, so from the baby's father as well as the mother, and also sometimes from a previous child, whether affected or unaffected. Now, if the couple haven't had a previous child, or we haven't got access to perhaps the father or another child, then we might not be able to offer NIPD. And finally, like any test, there's always a small chance that there may be an inconclusive result, or the sample may fail, for example, for technical reasons. So we're now going to come on to our case study, and our case study involves a condition called retinoblastoma. So before we talk about our family in more detail, we're just going to give you some background information on retinoblastoma, because it might be something that not many people are aware of. So you may have heard of this condition. Sometimes you hear about it in the news, where perhaps someone in the family has taken a picture of a newborn baby and they perhaps post it on social media, and someone notices that there's a glow or a disc, a white disc in one of the eyes. And in fact, if you can probably just see on the baby in this slide here, the baby's left eye has got a sort of paler disc in the center, and that could be indicative of retinoblastoma. So what is it? Well, basically it's a form of eye cancer, and it affects about 1 in 15,000 to 1 in 20,000 live births every year in the UK. It's caused by variants in the RB1 gene. The RB1 gene is located on chromosome 13. And RB1 as a gene provides instructions for making a protein that acts as a tumor suppressor. So where you get variation within that gene, or changes within that gene, that can inhibit the action for making that protein, and therefore that can result in excessive cell growth and hence cancer. There is good news, though, in that it is a very treatable condition, and the cure rate can be as high as 99% if we identify it early enough and if it's confined to the eye. In England, we have a national retinoblastoma service, and treatment is coordinated out of 2 centres. So we have one centre in Birmingham and one centre in London. So in terms of inheritance, about 45% of cases are inherited, and it's inherited via an autosomal dominant inheritance pattern. And where it is an inherited form of retinoblastoma, then it's often bilateral, so we often see tumours in both eyes. Genetic testing is available, and we can offer it where retinoblastoma has been diagnosed perhaps in a child or baby, and also where there's a family history of the condition. If we find that a child is found to have a variant, we can then offer enhanced surveillance so that tumours can be caught early and then treated immediately. And of course, that improves the outlook for those children. So in terms of NIPD, it's now available in some cases for a singleton pregnancy where a mother, a father, or previous child has been diagnosed with the condition. It was first available in 2016. Initially, it was just available for paternally inherited cases only. But in 2022, it was included in the National Genomic Test Directory and can now be performed for paternal, maternal, and also likely de novo cases. We process the samples at 2 labs at Birmingham and London, and Birmingham have performed a series of 23 tests to date, and so far all those results are concordant. So that means that the results of the NIPD matched the situation in the baby when checked after birth. So onto our case study. Our case study involves Jane and Adam. Adam has a heritable form of retinoblastoma that was diagnosed and treated when he was a baby. They decided as a couple that they wanted children, but they wanted to avoid having a baby with the same condition that Adam has. So they have a child called Ben, and Ben was conceived using pre-implantation genetic diagnosis. And that's a process where a couple goes through IVF and the embryos are tested to see if they've inherited the genetic variant from the father in this case, and then only healthy embryos are reimplanted into the womb, and that resulted in Ben. So the couple were very happy, didn't want any other children at that. They were very clear that they would never consider termination for any reason, and therefore they wouldn't have had prenatal diagnosis because they wouldn't have wanted to risk miscarriage. So they were very sure in that. And having had one healthy child, they decided that's it, we're not going to have any more children. They didn't want to take on that risk of retinoblastoma. So that's fine until Jane, at age 42, finds out suddenly that she's 9 weeks pregnant in an unplanned pregnancy. Jane then goes along to that first midwife appointment, which we call the booking appointment. And the midwife there takes a medical, social, and family history. And she notes at that point there's a history of retinoblastoma, and the midwife correctly recognizes that this is a genomic red flag, and that as a genetic condition, then she offers referral to genetic counselling and fetal medicine to Jane. However, Jane declines that, and she declines it because she says that, well, I had counselling before and during my last pregnancy. I wouldn't want invasive testing. I understand the risk. We wouldn't terminate for the condition, and that she's already had a long conversation with Adam, and they decided that they could cope if their baby had retinoblastoma. So they're just going to continue the pregnancy as is. Now, of course, she's basing these decisions on information that she gained during past encounters with clinical genetics. And at this point, neither Jane or the booking midwife are aware that NIPD is now available for retinoblastoma. In fact, Jane at age 42 is far more concerned about the fact that that carries an increased chance of Down syndrome. And that's sort of consuming her and sort of takes over part of the booking, really. She then opts to have combined screening, and because of her anxieties about Down syndrome, she is referred for a conversation with the screening midwife to discuss her combined screening results. She gets a low chance of Downs on that combined screening test, so she's reassured about that, doesn't want any more tests. But at that point, the screening midwife notes the history of retinoblastoma and thinks that NIPD might be an option. So the screening midwife does the right thing. She contacts her local genetics department and explains the history. And the genetic counsellor said, yes, we should probably see this couple because NIPD probably would be an option. So the screening midwife contacts Jane and explains what NIPD is. Would they like to talk about it in more detail? So they go along to the genetics team, and after a detailed sort of family history and discussion, the genetics team say, yes, we can do a bespoke form of NIPD. We have to do a pre-test workup, so it's going to take a little while. So they go through that, they proceed with NIPD, and then at 20 weeks, the results come in, and it's good news. The baby hasn't inherited the variant that Adam had and will not develop retinoblastoma. So this is great news for the family, of course, and it's means that they don't have to worry about it through the second half of their pregnancy. They can look forward to their baby and know that retinoblastoma isn't going to be a problem. However, if it had have been positive, then the couple would have had time to prepare for having a baby with this variant. And then of course, we could have implemented a detailed antenatal and postnatal management plan to prepare in advance of the birth. So again, we want to give you some key takeaways from this case study, because on the face of it, it sounds fine, right? This woman comes along, it was picked up that NIPD could be offered. She had NIPD, and of course, it was a good result. However, there are a few things just to highlight. And I've already mentioned that NIPD is available from 8 weeks of pregnancy, and that we can often do NIPD and get a result back before invasive testing is possible. Now, in our case, if she had been referred at booking, then we could have brought forward the results by a few weeks. And it might not sound that's a big deal, but believe me, it is a huge deal for parents who are at risk of having a baby with a genetic condition, where every week or every day not knowing just creates more anxiety. So early booking and early referral is essential. Also, delaying NIPD may reduce options for people. Now, again, in our case study, Jane was clear she would never have a termination for any reason, but some couples might have a termination, might consider it as an option. And if we delay NIPD, then it may reduce the options for those couples who may consider termination. There are rapid developments in genomics and things are changing all the time, and sometimes it feels like it's changing on an almost daily basis. Jane thought that she knew all her options, but this was based on her past experience and past discussions, and things have changed significantly since she had her first child. And in reality, in our case study, it was only luck that the screening midwife identified that NIPD might be an option. So what we would say is, where there's a history of genetic or genomic condition, it's always worth checking out what's new in each pregnancy, and or ideally before someone conceives, because testing and treatment options may have changed since previous experience with genetics and genetic counselling. Midwives don't need to know, and indeed can't know, everything about genomics. And I think it's fair to say that neither Joe or I are experts in retinoblastoma, but it doesn't matter. What you need is an understanding of the fundamentals. And if you understand the fundamentals of genomics, it can help you identify and act on those genomic red flags that we might identify preconceptually or at booking or at any stage in the pregnancy. And so having that genomic knowledge can empower midwives to support and empower parents to make informed personal choices about their care. We wanted just to give a couple of pointers about the future and what the future might look like for NIPD. And the first one, really, I've already touched upon, and that is the expansion. And in terms of what I'm talking about here, really is the range of conditions for which NIPD is available for, and the circumstances where we can offer NIPD is likely to expand in the future going forwards. And I've already mentioned, of course, that any minute now we will be able to offer NIPD in England for couples in a consanguineous or close relative relationship, and that's a huge step forward. We're likely to see NIPD being available for more conditions in the future as well. Again, but they has to go through research and then has to be agreed by NHS England or Department of Health going forward. Secondly, I just wanted to mention research in terms of the generation study. So the generation study is probably one of the biggest or most important research program in genomics in England since the 100,000 Genome Project. And what we're aiming to do is undertake whole genome sequencing on 100,000 newborn babies to try and identify some of those 9 babies born every day in the UK with rare genetic disease, where we can offer a treatment and make a difference. Now, we're going to be looking for over 200 different conditions on the generation study, and one of the conditions we're looking for is retinoblastoma. So we are going to be looking for variants in the RB1 gene. And this is important because I said that 45% of cases of retinoblastoma are inherited. So there are many cases that are de novo or new. And this might be a way to identify babies with those forms of retinoblastoma where there's no family history, early, as soon after birth. And we will come back later in the year, I think, and talk in more detail about the generation study, because it's such an important research program in genomics. So this slide is just giving you some information about where to go if you want to find out more. First of all, about retinoblastoma. So we have a Childhood Eye Cancer Trust, which is a support group for the condition in the UK, and there's some information there on the NHS website. And then if you want to know more about non-invasive prenatal diagnosis, then again, you can go on to GeneNotes and have a look about more information about that test. I'm going to talk more about GeneNotes on a slide in a couple of minutes as well. Today, we don't have time to go into the intricacies of NIPD and the different types of NIPD. It is quite complicated, certainly from the lab perspective. And as Joe said, neither of us are scientists. But there is a really good video on YouTube of a webinar that we recorded a couple of months ago, and one of our laboratory scientists from Birmingham is talking in detail about NIPD. So if you want to know more about it, then go and have a look at that video. It's only an hour long. It's available on YouTube, and we've also got another case study there which just gives you a further example of where we might use NIPD. And then the last resource on there is a paper from the team at Birmingham just detailing the series of NIPD for retinoblastoma that they performed in their lab. So we're just on to the final few slides now. So we wanted to give you something to take away, some resources, and we call this our sort of genomic toolkit, really, to support you, to support parents, to empower midwives and empower parents going forward. And I think the word genomics for midwives can be a bit scary, but I say that midwives are already genomics practitioners. It's just that they don't always realize it. And certainly we already have, as midwives, we have advanced history taking skills. And what we want to encourage you to do is to be more genomic curious at booking, to help you to identify those genomic red flags. How can you do this? Well, upskilling and learning more is a really good place to start. We've got the NHS England Genomics Education Programme. There's lots of free resources on that website that you can access. Now, sometimes it can be really confusing to know where to start with these resources. So a new initiative that we've developed is the Genomics Learning Passport for Midwives. And this is basically, it's a guide to all those key genomic learning resources, starting at the very basics, starting at what is a gene, what is a chromosome, what is genomics, and then increasing in levels of complexity. It's a Word document, so you can download it from the Genomics Education Programme website and then just work through the resources according to your sort of sphere of practice or however much you want to do. And hopefully that will help you navigate your way around the resources that are out there. There are also some other good resources available. The National Genomic Test Directory, we've both mentioned that. We've just put the link there. Our colleague Denise Barnes, who's lead midwife in northeastern Yorkshire, developed a great little prompt card on genomic red flags. And these are cards which highlight the kinds of questions that you should be asking at booking and highlight where perhaps to probe further to find out more about somebody's history. Also gives you details of how to refer on, who to refer to, and these are available to download free from the Northeastern Yorkshire website. And then we've just put the link to G-Notes, which both Joe and I mentioned. So G-Notes stands for genomic notes, literally, and there's lots of information on there. You can just type in a condition, or perhaps if you found something on scan like short long bones or fetal ovarian cyst, you can kind of type it in and it will give you information about whether that's a genomic condition, what kind of testing you should be offering, and perhaps where you might need to refer on. So great, concise, good quality information available at your fingertips. And then finally, it's important that you know who to go to access further information or advice. And we strongly recommend that you know who your local genetic counselling service is, because I think it's fair to say they would always rather hear about a case sooner rather than later. All genetic counselling services have a prenatal team, and they encourage midwives to contact them, but the method of contacting them may be different according to where the service is. So if you're not sure who your local genetic referral services in your area, this is in England, then you can go on this website. There is an interactive map and you can find out who your local service is. And sometimes it might just be a case of finding out who is interested or expert in genomics in your trust, whether it might be a screening midwife or fetal medicine midwife or consultant, where you might just need to pick up the phone and ask for advice. It's also important to stay up to date with the latest genomic advances, and there are lots of ways to do this, but there's lots of newsletters and networks out there. All of the GMSAs, as far as I'm aware, have a newsletter that you can sign up to. The Genomics Unit at NHS England have a newsletter, as does the Genomic Education Programme. That's a great way of just finding out what the latest developments are. We also have National MIGSnet. So MIGS stands for Midwives in Genetics and Genomics Network, and we meet regularly every month. We invite people to come and listen in, either as observers, or we're also looking for new members. So if you're working in England and particularly interested in genomics on the maternity pathways, then drop us an email. Well, at the moment, actually, we're looking for anyone who's got a particular interest in neonatal care. So drop us an email and we will invite you along if we've got space to do so. And then finally, last but not least, there are many local and national support groups out there which can help you to support women, people and families in your care, and also help you with information and support and advice as well. And we can't list them all, there are many, but the Genetic Alliance UK is a really good place to start, and that includes a directory of organisations across England where you can find out whatever condition is, find out what support groups are available. So I think that's my last slide. Thank you everyone for listening, and I think I'm afraid we've probably just reached our time, but I don't know if we've got time for any questions.
Well, thank you both very much. I have one question really, which is about, I mean, this is a fantastic presentation and I'm very, very excited by it. Both of you are deeply into it, but I have to admit it is quite daunting and it is quite scientific. And can you just, Joe, elaborate a bit more about how you're hoping to engage with midwives over the coming year to give them the confidence to recognize what they can do and should do, without having to become a genetic scientist?
Yeah, so I think for us, it's just really honing in on what midwives are already doing, what their skills are, as Karen mentioned before. A lot of midwives are routinely taking a family history or thinking about a person autonomously, and it's just trying to link in some of those key things. Is there a family history of a heart condition? What does that mean for that person that's sitting in front of them? Is there someone who may have had multiple miscarriages in their history? Has that been reviewed? How long ago was it? Do we need a fresh look on things? And then just, I think, we don't want people to go away thinking, oh my God, I've got to go away and do a genomic master's. It is about going, what are my referral pathways? Is it that I just need to make sure I know about my screening midwife and my screening team? Do I need to know about the fetal medicine team and refer to them for questions? Or am I going directly to those genetic clinicians? And if you don't know who they are or what those pathways are, then that's what I suggest you go back to, and just start being a bit more inquisitive. As you say, me and Karen are going to be presenting in Nottingham. So, we're free there to have some, conversations and highlight some of those genomic red flags as well.
And if I could just add, actually, if you don't mind, and one of the things I didn't mention and perhaps should have done is that in terms of NIPD, all referrals need to go via genetic counselling. So we're not expecting midwives to counsel on the finer points of these tests. They have to go through genetic counselling. And sometimes, I had a case once where a midwife just phoned me up and said, Karen, I think I found something a bit genetic-y. And that was enough. She'd recognised that red flag that we talk about, and that was enough for me to then explore things with that family and then refer to genetics. And that's what we want midwives to be able to do, is just recognize those genomic markers.
And finally, a question about in screening and things in relation to Black and Asian minorities, and some of the questions and some of the conditions that might be more prevalent in those communities. I've been reading some stuff on the websites, but how much is that really for adults, or how much of that can be indicated at the time of pregnancy and questions asked? Karen, Joe, which is you?
I suppose there are certain genomic conditions are going to be more prevalent in certain communities. So I don't think you can just talk about one sort of ethnicity or heritage. So again, it's just about asking, regardless of people's backgrounds, it's just important about asking about family history, whatever their background is. I don't know if that helps.
Okay. Well, thanks to both Joe and Karen, and thanks to everybody who's joined us today. This will be available on a podcast on Friday, and it'll be available in Matflix and on our websites. And as they said, we're looking forward to either seeing you in Nottingham on the 20th of May or watching online, which you can do from anywhere in the UK or indeed anywhere in the world. And we'll be revisiting this issue, which I think, as Karen was mentioning, is going to grow and grow because of the speed of developments and the conditions, and some of them very rare, but nonetheless at the centre of things that have puzzled maternity and midwifery for generations. So thanks to both our speakers, thanks to everybody for watching, and see you next week.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's a real trailblazer.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators, anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day